Welcome, Dr. Todd. I introduced you already as an alloy prescribing physician and OBGYN. We are big fans of the wonderful Dr. Todd. And I just mentioned to everyone that, as always, we're going to be talking about menopause, but as it is the first perimenopause awareness month, we're sort of highlighting here the topic as it relates to those of us still in perimenopause. So today is GSM, and I also said to everyone that I am guilty of still saying vaginal atrophy, for which I said I then have to atone, but I didn't want to pronounce the GSM because I always get it wrong. So I'm gonna leave it with you, and I'm gonna let you first let us know what is GSM, what is the proper terminology, what should we be saying?
Okay, so genitourinary syndrome of menopause, that is what it's for. And vaginal or vulvovaginal atrophy component of that. As the genitourinary system has the vagina, the vulva, that's the external part of the vagina. The bladder is also included in that. And so we want to include all of the symptoms that may encompass what we call the genitourinary symptoms of menopause. And that includes the dryness of the vagina. It also includes people who get urinary symptoms such as frequency or urgency, incontinence. All of that is included in that GSM term.
Great, thank you. So I mentioned before you jumped on that most of us, or certainly I did, think that GSM was a postmenopausal issue, but it can in fact start in perimenopause. How can women in perimenopause recognize symptoms of GSM?
So honestly, in perimenopause, you will notice them more starkly than menopause. And let me define what I'm trying to say, because basically you have kind of a quicker drop in menopause, in perimenopause, of your hormones. And so you're getting that drop in hormones, and you start to recognize other symptoms, but then you start to figure out, what, something's going on down below. I'm having more dryness in the vaginal area, or I'm starting not to be as comfortable with intercourse as I was prior to, a few even weeks ago. I remember thinking the same thing for myself. In fact, that's how I noticed that I was really getting close. That was the first one of my first that I recognized. I had other signs, but that was one of the first things: the dryness and the pain, the discomfort. You know what? I'm not as comfortable with my same partner as I was before. So those are kind of the signs that you can recognize in the, that vaginal area or vulva area. Even itching. Some people will have vulva itching initially. They come in and I got yeast infection. There's no yeast at all. It's just the changes that the vagina is going through to indicate that something is changing and something is different. And it's usually as it relates to the decrease in the hormones.
Okay. And so when should women consider treatment? And I guess what I want to also sort of say is, or ask is, in perimenopause, is it too early? And what can you maybe, I guess, with that sort of couch perimenopause, when it might begin? So how early is too early? If a woman says, listening to this conversation, hears you saying, these are some of the symptoms to look out for, this is how you might recognize it, and she's 38 and may think this doesn't apply to me, what would you tell her? What would you tell a patient coming into your office who is complaining of these symptoms?
So what I would say is, it's perimenopause is more nuanced, and unfortunately we don't have a whole wealth of studies or education regarding it. And when you have a patient, so you say menopause, average age is 50. We have 10 years where we can have a transition, so that's 42, right? But if your family history indicates that your mother went through menopause at the age of 45, then you might be 35 when
Right.
you are.
Okay.
So, perimenopause is, I can't say that it's a big, you can't put everybody in the box of
Sure.
perimenopause, because there are different ages that these things can arise in the natural state. Of course, for patients who had, ovaries removed, um, even just one ovary removed, they may get symptomatic sooner. They may still have some menstrual cycles, or if they've had chemotherapy or radiation or any other thing that might affect their ovarian function, they may feel like, okay, something may be going on, and I'm 35, I'm 32. It's still something not right, and I need to investigate that. I need to see a clinician in person, let them take a look. One of the things, like I said, if you start getting itching and you found that, oh, you know what, I am going back and forth to different providers and I'm not getting any answers, it could simply be something, the genitourinary symptom of menopause in perimenopause.
Right.
Don't discount it because of your age. Age is a number, but it's not a physiologic uh, process that dictates how your body is going to respond to the drop in your hormone.
Terrific. Thank you, Dr. Todd. I just want to chime in and say somebody wrote in, I have my HRT and vaginal cream with my alloy, and it changed my life big time. Thank you. Okay, so talk to us, Dr. Todd, about what the treatment options are.
Okay. So, and a lot of what, we look at, of course, there's non-hormonal and there's hormone.
Right.
Non-hormonal treatments can include anything from, people will use the over-the-counter lubricants. There are silicone-based lubricants. There are water-based lubricants. There are oil-based lubricants. All are safe, but they do say that oil-based lubricants will diminish. So you might want to, be very careful of using those if you're going to be using barrier methods of protection. But there's several different options for any of this. Hyaluronic acid has been tested as well as a non-hormonal option for vaginal health. And what they find is that, it's better than placebo and pretty equivalent in some patients with, vaginal estradiol. However, vaginal estrogen is the gold standard. It is the treatment of choice in most cases because the receptors in the vagina, they're very dense for estrogen. So they want estrogen in the inside. The external is more like a testosterone. So you also have DHEA preparations like progesterone that also help with vaginal symptoms or genitourinary symptoms of menopause. Because this is a hormonal treatment, it actually converts to both estrogen and testosterone. And of course, there's vaginal testosterone, but mostly those testosterone is used in combination with an estrogen. So it usually is a compounded formula. But again, I cannot reiterate, the gold standard for treatment is vaginal estrogen. It's specifically estradiol. It penetrates or estriol. Those two penetrate the vaginal receptors to a point to really build up that tissue, because that's what you need. You need the building of the tissue, the restoration of moisture, the collagen production, the elastin production. You need that elasticity so that you can have function in that space. And also to decrease the risk of those bladder symptoms, such as infection and urinary frequency, urgency, those types of things. All of that space gets built up, and then you have less of those abilities to have infections, or less of the abilities for that bacteria to build up and backtrack into the urethra. So it's very important, and I think vaginal estrogen has been shown. Now, I don't know that hyaluronic acid has been shown in terms of prevention of UTI type symptoms, but I think when you compare it, like they say, to vaginal estrogen, they say that it works pretty well. So in most.
That's so helpful. Before you joined, Dr. Todd, we were talking about that very briefly, just sort of what other things women might think to use correctly or incorrectly. And I was laboring to sort of say that I think the thing about vaginal estrogen is it's something else. Estrogen is its own thing with its own function. And there are other things that might mitigate itchiness or discomfort or dryness even, but it really isn't the remedy or the cure to what's actually going on. Does that make sense?
That makes sense because, again, like you said, it remedies the short-term problem or, the problem at the time, but it helps the itching, but it's not going to restore tissue balance or the lactobacillus. It's not going to restore the collagen and elastin and all of the other things that, the vagina has in it, components to make it a space that is functional.
Thank you. Dr. Todd, so localized estrogen, which would be the vaginal estrogen, versus systemic therapy. So for women in perimenopause who may not yet be candidates for full MHT because they are still getting a period, can localized estrogen, I know we're sort of repeating ourselves, but I just want to give you a chance to expand anymore, provide that early relief for GSM? And how do they work sort of differently in perimenopause compared to later stages? So that's localized versus systemic.
Okay. So systemic estrogen, we know, has been FDA approved for menopause, but that doesn't mean that you cannot use it in perimenopause. If you have, thank you.
That's so nice. She's great. That's so nice.
If you have vasomotor symptoms, so a lot of patients get night sweats in perimenopause. I'm gonna veer off just a tad.
Sure.
Sweats in perimenopause, and with that, they don't even recognize, wait, why am I sweating when I'm sleeping? What's going on? That is a vasomotor symptom of menopause. Okay, so if you have contraception on board and an alternative form of contraception, then you could probably have menopausal hormone therapy in perimenopause. It is not unsafe because regardless of what's going on, your estrogen levels or your hormone levels, estrogen, progesterone, they're dropping. And so that drop is the reason why you're having those symptoms. But let's go into the vaginal or the genitourinary symptoms of menopause or genitourinary syndrome. Those will also be impacted by that drop in hormones, and even more so because the rest of the hormones that your body is still producing, it's kind of trying to take care of the receptors everywhere. Whereas, your brain, your heart, your kidneys or gut, all of those are essential and vital organs. Well, the vagina is and is not a vital organ. And so consequently, the receptors, as dense as they are, and they're trying to take up what little it has less to give from, your own production, the vagina is trying to take as much of it up as it can. But if it doesn't have anything to take up, it's going to go through those symptoms of especially atrophy. Atrophy is that symptom that will cause the itchiness and the dryness and the pain with it. So if you don't have enough to give those receptors, that is why in perimenopause, you still have enough, you just don't have enough for everything. And so then you tend to give those receptors that localize estrogen in there. So it just soaks it up like a sieve. Here it is, here you go. And the vagina acts like a sponge. It is its own delivery system for medications. And so we can put it right on it. It takes it right on up and it makes it, a happy space. So
that's so wonderful. Thank you so much. Just very, very, very quickly, deviating for a moment. For women who use or apply progesterone into the vagina, should you be aware of when you are using vaginal estrogen and you're inserting your progesterone, or meaning aware in that you shouldn't do both at the same time, or it really doesn't matter?
No. So it does. Here it is. You would want to put the vaginal progesterone, the progesterone capsule. You would want to put that in first because you're going to put that deep into the vagina.
Okay.
The vaginal estradiol is used at the lower thirds of the vagina. So it doesn't have to go deep in there close to the pill. So you can use them the same day. And the nice thing, I mean, and there are different types of vaginal estrogen. There are pills, there are rings, uh, you know, the creams. The one real reason why I love the cream, though, is because, and I'm just going to talk about, anecdotal for myself. You can rub it on the external surfaces and you can get that tissue to get stronger and built up and more collagen and that skin, more moist. So you don't have, you have that benefit of being able to put it all over as opposed to just in the lower third. So you can use, you just put your pill, your capsule for your progesterone in first, and then you just use your vaginal estrogen.
Okay.
Okay.
Thank you.
Another, I'd like to talk about intercourse because, yes, because one, people say, well, what about the days I have intercourse? What if I have, frequent intercourse and, I'm supposed to be using it every 2 to 3 days? What about that? Well, we say, okay, go ahead, do what you have to do in terms of intercourse. Most physicians will recommend that you void after intercourse, so that is urinate to prevent, any UTIs and what have you. And then you would insert your estradiol after that, or your vaginal estrogen, I should say, after that, your cream.
Thank you for that. I'm so glad you brought that up. And you made me think of another question I have heard women ask, which is if I'm still getting a period, and I remember specifically one woman saying it's not really anything to write home about, meaning not a heavy bleed. Should I, because I think for some of us, we get a little in the weeds about keeping to a schedule for the vaginal estrogen. So this one woman had said, can I use it on the days that I have a bleed, or should I not?
Okay. So I what I always recommend is that, there are days when you have menstrual cycle heavy days, there are lighter days, etc. So say for instance, you start on the first and it's light for 1 or 2 days. That is the time you want to use it. Let your heavy days go by. Let them go by. You've already gotten it, your treatment for that part of the week. And then, once that heavy day finishes, especially if your heavy day is, day 2, 3, or 4, if you have to skip 3 or 4 days, it's okay, because if you have been doing the treatment as prescribed throughout the time, if you feel like, this is too heavy, too messy, I can't deal with it, then use it when the lighter days come or when it's pretty much gone. Then you use it. So you again, it's really nice to say, yeah, I use it every other day pretty faithfully, but in menopause, we can do that because there are no periods. However, in perimenopause, if you need that treatment and you're still, like we know you are still cycling, then you have to nuance how you use your treatment and focus on your treatment those weeks that you're not having your period. And then once the menstrual cycle starts, then just kind of nuance when you can use it thereafter.
Great, thank you. Dr. Todd, are there any proactive steps women can take in perimenopause to delay or mitigate the onset of GSM?
So that was a question that I was thinking about all night, because I was like, can you do to mitigate? Because of course, your ovaries, they're going to decrease production of hormones. So, now how do we focus on prevention of that, delaying or what have you? So I couldn't find anything in the literature that says that, but here's what I think. The vagina has to be acidic. Lactobacillus is prominent, and it should be prominent in the vaginal space. So consequently, if you can do things to keep that lactobacillus prominent, then that will delay. That means keeping the vagina healthy. If you're concerned about, do you have an infection, that means, go get seen to make sure that the infection is taken care of. Also, your menstrual bleeding will make your vagina alkaline. So, as soon as you can, you want to try to restore that acidity. There are things like boric acid you could do that with. There are things like I know I've often recommended refresh vaginal gel across the counter because it also restores the pH. But things that will restore the pH of the vagina will you keeping that vagina tissue healthy and free of infection, and maybe prolonging that I guess genitourinary syndrome, so to speak.
Okay.
And lubricant.
Thank you.
Oh,
Right.
and one more.
Yes.
And Instagram is gonna let us say this, but having intercourse, having intercourse, being active in intercourse helps keep that vagina healthy because it's a constant. I guess it's kind of like working your muscles. It's constant activity and making that tissue continue to remain restored and rebuild.
Fantastic. Yes, I remember years ago having a conversation with the urologist who said, use it or lose it. Meaning, right? Like it, you have to kind of literally, for lack of a better way of saying it, sort of exercise that muscle and area to keep it healthy. It contributes to its health. Dr. Todd, I just want to take a break from my questions to take a look at some of the questions that came in. I'm going back. Several people saying, they're so thankful to Alloy and have recommended Alloy, and that's wonderful to hear and know. Sorry, I just saw a big question. Just give me 1 second to find it for you. Here's one. Why do I still bleed? I'm 60 years old. I've been on HRT since I was 54. My doctor does, I can't read what that says, sorry, U/S on me to always watch me and says nothing serious. May need to do a DNC, I think is what she meant to say.
So, again, natural occurrences of menopause, again, is unique to everybody. And yes, U/S means ultrasound. And a lot of physicians will do ultrasounds to look at the endometrium to see, is that the problem? Because a thickened endometrium inside the uterus can mean cancer is developing. So ultrasounds are used to make sure that that isn't the case. Now, in terms of the bleeding, it depends on where the bleeding is coming from. If you're having periods, well, yeah, I would definitely do ultrasounds. And yes, I would definitely really do sampling, because even though you've been on hormones, and I'm sure it would be estrogen and progesterone, because progesterone is protective if you have a uterus, we still can't say that there isn't a polyp there or something else there that can transform. So we want to make sure, fibroids, something like that could be the source.
Okay.
If you're having light bleeding and it's not even a regular period, it could be just a vagina source, and it could be because the vagina is so thin and so friable if you've been using systemic hormones only and not anything in the vagina because you didn't feel as though you needed it because everything else was taken care of and you wasn't really using the vagina that often, then you might just be bleeding from that, and it could be periodic, it could be even monthly, but mainly just keep up with your doctor at the age of 64. Although you've been on hormones, I agree your doctor is surveilling you correctly. I think an endometrial sampling would be in order, and that's what I would do in my patient. However, if I had done a couple of samplings and still happening, again, I just keep an eye on it and make sure that nothing else is going on.
Great, thank you. Another question you have is, can you discuss breakthrough bleeding? I'm on 100 milligrams of progesterone taken vaginally, 3 sprays of Evimus.
Okay. Yeah, so breakthrough bleeding is just one of these things that it annoys everybody because it's all when it's inopportune for that to happen. And when you have a certain amount of estrogen, it could be, estrogen is supposed to stabilize the lining, whereas progesterone and estrogen together allows for that implantation, that thickness to remain, and then that shed. Sometimes the breakthrough bleeding could be due to the fact that, you might have to back off the estrogen just a little bit, because it's just, your lining has gotten just a little bit too thick, and it's just kind of shedding in times when, I don't, it's just not stabilized. That feedback mechanism is just not causing it to stay there. The other thing, as it relates to breakthrough bleeding, is there another reason why you're having it? Is it a polyp? Again, a structural concern of the uterus, a polyp, a fibroid, something like that going on. So when you have it and it just doesn't seem to be abating at all, it comes all the time. I'm all over the place. I can't take this. It's been going on for more than 6 months. I would definitely see a provider in person just to make sure that that bleeding isn't something more ominous happening. And it could, again, just be something super benign. It could be something related to the hormone feedback, but it could be something else too. So I always recommend that, hey, get seen, and then we can try to figure out how to fix it.
Thank you. One more before I get back to these questions, and I know we're getting short on time. So no. Someone wrote, I had an allergic reaction to estradiol, feeling discouraged. What are your thoughts? And if I might also add, I'm not sure if this is the same person who earlier, right before you joined, had mentioned, what if you're allergic to vaginal estrogen?
So could be the components in the cream. I'm assuming that would be the cream that this person was talking about. It could be some of the components in that. But if you are allergic to vaginal estrogen, the whole thing, the estrogen just doesn't do well for you. You could get hyaluronic acid. Like I said, in the studies, they said that, it seems like that's something that helps, build up the tissue as well, restore that moisture for sure in those cells. The other thing you could potentially use is the progesterone. That's the DHEA product, because it's going to convert into estrogen and testosterone, but the initial application is going to be DHEA. There's also aspina, aspifamine, I think they call it. That's also a product that you can use. It's a selective estrogen receptor modulator, so it's not actually estrogen, but it does bind to those receptors in the vaginal space and help restore that tissue to its better integrity. So those are options that you can try if you're allergic to the other thing some people will do is have it compounded in like oil, or I had a lady who asked for it to be compounded in coconut oil. So
we were talking about that earlier. Well, go on. I'm sorry.
Yeah, we were able to get her estrogen in that compounded coconut oil, so that she could have her treatment without the additives that caused her discomfort.
That's so interesting. Is briefly, someone had mentioned that coconut oil can, I'm trying to remember what she said now. It's not so great. I think it causes fungus. But to your point, and what you're saying is having the estrogen there, I'm sure, is protective. So it's not like using just plain old coconut oil. This is something else altogether. Dr. Todd, I know we're going to wrap up soon, but there's one more question I see that I think if we can home in on this one for a second. Can atrophy be reversed with vaginal estrogen? What would the regimen be if this is, I think, maybe a separate question. What would the regimen be if there is uterine wall thickening as well, specifically 14 millimeters? Already had 2 DNC procedures. This woman is postmenopausal.
Okay. Yeah, a 14 millimeter endometrium is pretty thick for a menopausal person. Not so much for a perimenopausal person. So I'll clear that up right now. It's maybe just slightly, but not so much. Now, in terms of vaginal estrogen, you can, even with that, you can still use it, because remember, it is localized treatment. And in every single study that I looked up, and it was probably about 6 or 7, even including meta-analysis on thousands of patients, they cannot find a place where vaginal estrogen has increased your systemic estrogen, which means that if you don't have it in your bloodstream, it cannot affect that endometrial lining. So, I agree, have that conversation with your physician, but at the end of the day, it should still be safe, even with a slightly thickened lining for a perimenopausal patient. For a menopausal patient, if you need it, the other thing you could do is just use just a tiny bit. You don't have to use the 1 gram, the whole 1 gram. You can use just a little bit and rub it on the external vulva and right on the inside of the vaginal space. Surely just that little, remember 0.1%, so it's 0.01%. So it's a tiny amount of estrogen. So again, if it's just not going to impact the endometrium.
Sorry, I didn't mean to cut you off. I was just thinking of getting to the end of our conversation here, but I remember, Dr. Todd, that when we talked about what we were going to talk about today, you had just come from a conference, and I can't remember whose it was. And I just wanted to give you a chance to, if there's anything you feel maybe you learned in that conference or was particularly impactful for you that you wanted to share with us about this particular condition, I'd love to hear it. I don't mean to put you on the spot. I just, if there's anything that you wanted to add.
That's fine. Actually, me as a traditional, gynecologist, I always think in terms of how do I treat women with hormones. Well, when I went to that conference, and it was a 1-day online conference focusing on the genitourinary syndrome of menopause, I then got to focus a bit more on those non-hormonal options that are there for treatment. And again, just like some of the questions you came up with, what if I'm allergic, or what if I can't tolerate? So, we got to talk about all of those things. And also, I learned how it impacts the urinary system and how important it is for us to keep our vaginal system healthy so that our urinary system stays healthy. And I also learned about the use of testosterone, because we don't do a lot of testosterone. We don't have the ability to prescribe it online due to, it's DEA, being on the DEA list. But, topical testosterone can be very helpful, especially externally. So I learned that different cell types, it was so enlightening to me, because again, I used to just focus on, take the estrogen and that should help. And then I would, I don't have very many people coming back though. I'll tell you. I mean, people are like, yes, this has. I don't have very many people coming back and saying, no, something's not there. But now if I do, I can then counsel and say, okay, let's try some other therapies for you. And also physical therapy for the pelvic floor. That is something I count a lot about, getting that whole, because that's a big muscular structure holding our pelvis. And that pelvic floor physical therapy is so important in keeping the integrity of the vagina and decreasing the genitourinary syndrome of menopause as well.
Thank you so much, Dr. Todd. This has been a fantastic 43 minutes. I am so appreciative. You're chock full of information. For any of you who may have been listening, have questions for Dr. Todd, hopefully you can be routed to her through the Alloy platform. I know that she sort of covers a geographical area in the United States. She is in Vegas, but please do, if you have questions, be encouraged. Speak to your prescribing physician. If you're not yet an Alloy customer or community member, jump on, connect with a doctor, ask questions that you have. I believe there's a fee of $49. I think it's $49 to connect with an Alloy prescribing physician. And that connection is active and available. That doctor is available to you to answer any questions as long as you have an active prescription. Dr. Todd is very loved. She's joined me often for Alloy support groups, and I'm really I love speaking with you and learning from you. Thank you, Dr. Todd.
Rachel, we always seem to have great conversation, and it helps myself up to speed.
I know you love to learn. You have you are a researcher, physician, clinician in all ways. So Thank you all. I saw very quickly somebody asked if we see people in person. We do not, and you will hear from our physicians all the time. You must go into a brick and mortar and meet with a doctor and have your pap smears and whatever happens to all of us in a gynecological exam. So make sure you continue to do that. Thank you, everybody. Thank you who joined today, and you'll be seeing us lots and lots over the next couple of months. Thanks, Dr. Todd.
All right.
Bye.
Y'all have a good one.
Everybody.